Okay, I think we'll get started. Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Labor's International Union of North America. My name is Leslie Rattan, and I'm pleased to be moderating our webinar series, which was developed for people that have sustained concussions, their caregivers, and healthcare providers. And as you'll know, if you've been to any of these before, sessions focus on various aspects of concussion and include an expert speaker presentation for the first half, and that's followed by a question and answer period for the duration. And the sessions too are recurring every other week on Tuesdays from 6 to 7 p.m. So tonight is our 20th session. If you've missed any of the previous ones, you can go to the Canadian Concussion Center's website, and we have all of those recorded, so you're able to watch them there. For this evening, if you have any questions after the presentation, please go to the Q&A. You'll see if you look to the bottom right of your screen, you'll see the Q&A area. So you just click on that, and that's where we ask you to put your questions, which will be addressed later. And if you're having any technical problems, please enter those into the chat, which is on the left side. So for this evening's session, I'm really pleased to introduce Drs. Michael Hutchison. And Dr. Hutchison is going to be presenting Return to Athletics, Principles and Who to See. And we're also fortunate to have Dr. Richard Wenberg, who's going to be joining for the question and answer portion later on. So Dr. Hutchison is an associate professor and director of the Center for Sport-Related Concussion Innovation and Knowledge at the University of Toronto, where he oversees an interdisciplinary clinical research team of health professionals for sport or physical activity-related concussion. He holds a PhD in rehabilitation science and is a registered kinesiologist. And his present research focus is in the areas of neuroscience, kinesiology, and rehabilitation. He also holds scientist positions at the Keenan Research Center for Biomedical Science at St. Michael's and the National Hockey League Players Association. Michael's research productivity is internationally recognized with over 80 peer-reviewed publications, and he's received over $6 million in funding, including principal investigator grants across all Tri-Council funding bodies. Michael is also the founder of Rhea Health, Inc., a University of Toronto health technology that uses evidence-based physical movements tailored to assist in the recovery of concussion and mental health conditions. And with that, I'm going to turn it over to Dr. Hutchison.
Thank you, Leslie, for that very kind introduction. And I'm obviously very excited to participate in a series like this. This is something that's definitely needed for our community, and the ability to share this information and help answer questions. If we can move the needle in people's knowledge base, understanding, and passion, then that's something that's well served. So today, this evening, I'll be speaking on Return to Athletics, the principles and who to see. I think Leslie did cover many of the potential disclosures of my background, but I think it is important to acknowledge those things. And here they are again for just my associated affiliations with obviously the University of Toronto, also St. Michael's Hospital, the NHLPA, and a couple other committees. Funding should be also, I would like to acknowledge in terms of potential sources of that funding, as well as the last one there, commercial interest. And that, admittedly is probably a conflict of interest that I have to also acknowledge in potential some of the communication this evening. And I will be sure to acknowledge at that point if I do bring up Rhea later in this conversation. So important to acknowledge those things. So it is a pretty tight here time. We only have 30 minutes, and we also want to save another 30 minutes to have hopefully some solid question and answer times. Discussion, obviously being a research institution and teaching institution, questions and discussion are always important aspect, and I want to obviously get there in a very timely manner. So I'm going to monitor my time. It's 5 after 6 already, so I think that means maybe I'm already 5 minutes in. But here's a brief overview of the agenda. I think even though maybe some participants have been to these sessions before, I do need to spend a few minutes on a concussion primer, just getting our footing and our understanding what we're talking about this evening. The focus will be return to athletics, but before we talk about return to athletics, we will have to, again, spend a little bit of time and energy just talking about salient acute management principles. And then then we're getting into the meat of the conversation this evening, really dealing with return to athletics and what's unique about that. What's unique about returning to athletics, but also at the same time, what's unique about athletes and why do we have to be aware of these things when returning to athletics? Half of the presentation will be focused on return to athletics and who to see, so that's the bulk of it. And then the fifth point there is that we will spend some time for discussion and questions. So that's the bearings, that's the framework of what we're working under. So let's starting off with what a concussion is. I do like this approach that I've been using in the last couple of years in defining concussion and hopefully appreciating that concussion is quite complex and multifactorial. But let's just start off at a very basic level of what a concussion is. It's a traumatic brain injury. And this is where we get into almost like the academic weeds, so to speak, defined as a complex pathophysiologic process affecting the brain induced by biomechanical forces. So this is when you get a whole bunch of clinical researchers and academics and you tell them to put on a piece of paper what a concussion is, and this is what you get. And I think if we kind of break it down, let's just try to simplify this a bit more. So, biomechanical forces, let's just start there. What does that really mean? That essentially just means an event, a collision, a fall, some type of contact, which then is going to affect the brain. And then let's break down complex pathophysiological process affecting the brain. Well, really what we mean by this is an alteration in brain function. And we can define this in certain ways based on aspects with respect to blood flow, energy utilization, I think is a big one, and how our brain uses it, how our brain cells communicate. And all these things go into that pathophysiological process. But if we break it down again into the most simple terms, there's an event, a collision, a fall, plus some alteration in brain function. And often if you watch maybe athletics or you see someone potentially suffer concussion, you may actually see certain behaviors. And we refer to those as signs. Those are visible observations that someone else can see after someone has had that event. Balance difficulty. Sometimes you may see someone vomit. That would be something you could see, someone else could see with their eyes. And then the other piece of the puzzle is how someone feels. And that was what we refer to as symptoms. Now, symptoms can have many different forms, and we'll get into that. But for the most part, they would be around physical, like physical issues, cognitive issues, sleep-related issues, emotional issues, sensory-related issues, across the kind of gamut of different issues. But nonetheless, someone feels unwell after having that event of a collision. So that's when we talk about the core issue of a concussion and that event. But then when you deal with a concussion clinically, you have to look at the other rings that are associated with concussion. And this is why I often say that concussion is multifactorial. Because even though you've had an event that has potentially affected your brain tissue and how your brain functions, you also have surrounding structures. And most often, we say comorbid, that means occurring at the same time as that event can also impact how someone feels. And for example, most commonly, it's neck-related issues that seem to be often comorbid at the same time of actually altering your brain tissue. And then we have what I refer to as premorbid. These are things that occur before this concussion that someone brings into the event before of the situation. So really, we have three really important rings. At the core, we have the event, the concussion itself. We have comorbid ring. That's other things that can happen at the same time as the concussion. And then we have premorbid ring. And that is things that people bring in to the concussion. And that could be prior concussions. It could be a history of migraines. It could be a history of mood disorders. A bunch of things can kind of sleep disorders. Anything that happens that exists in that person before they arrive at that collision, we would classify that as premorbid. So I'm going to work with this kind of framework, but let's just appreciate when you deal with someone clinically, you deal with these three different rings, and it's important to keep that in mind as we think about returning to athletics or just getting back to anyone back to their state they were before the injury. I want to quickly come through this concussion primary, the fundamentals. So in a concussion, even though I've acknowledged that it is a brain injury, most people have full memory of the event. And in the event I'm talking about here, whether if they went pleasure skating, they fall and hit their head on the ice, or if they're in a sport and they get elbowed playing basketball, they would have full memory of that collision. And they would also have complete recollection of before, so driving to the skating rink, right before the rink, and after, going home, not feeling well. And so now we say most people because sometimes people lose a brief piece of the memory of the event. They don't know how they felt. They don't know how that happened. That happens about 10% of the time. And then recalling before, well, I know I was pleasure skating. I was skating with a friend, but I don't know where I was before that. That would be not recalling before. That happens about 25% of the time, 1 in 4. And the same goes for after that. Even though there was an event, I don't know if I went for hot chocolate after, I don't know what route we drove home, I was driven home by, all those things. The next one is important as well, and I don't think this one gets acknowledged enough. Symptom onset should be in close proximity to the event. So again, if I potentially went pleasure skating and I fall and hit the back of my head on the ice, I should probably feel unwell relatively close to that event. And what I mean by that is about 50% of the cases, I would feel unwell. I would have symptoms within an hour. And then probably 75% of the cases, you would have symptoms within 3 hours. This idea that you could have this event, you could have this collision, acceleration of the head, hit my head on the ice, and then I don't have symptoms for 4, 5, 6 days later, that's not the kind of what we see most often. That's not a logical sequential issue around this injury. We see more often than not, symptom onset occurs for the most part 75% of the time within a 3-hour window. And now it doesn't say that we do accept that sometimes maybe 24 hours the next day, later on at school the next day, later on at work, some people may start to feel unwell. We do accept this window of 24 hours though. But the idea is that, last weekend I went skating and now I have headaches today. That's not very common at all. The next piece of the puzzle, if I take me as an example, I go skating, I hit my head on the ice, and I'm worried that, I have a concussion, I go to the hospital, and they potentially scan my brain in a CT scan or an MRI, it would be completely fine. Now, if I went to the hospital and that was to happen, they're not worried about a concussion. They're actually worried about that potentially I have something more severe, maybe a moderate brain injury, or maybe even something worse, who knows? But the idea is that concussion would not show up on standard neuroimage at the hospital. Point number 4 is that most people recover within 3 to 4 weeks. And this is important of expectations, like how long would it take if I'd fallen and hit my head on the ice? When would I be able to get better? And we would expect most people to get better within 3 to 4 weeks. Now, if you're on a pro hockey team, that may be a little bit earlier. If you're a bit younger, that may be a bit longer. But generally speaking, I'm safe to say 3 to 4 weeks is a safe bet that you should get better after concussion. Now, unfortunately, I say point 4. Now, if I move to point 5, this is where what we say is that there's big variability in recovery, because 30% of the people, when I say most, I mean probably like 50%, most people recover in 3 to 4 weeks. Well, we know that maybe 1 in 3 people take longer than 4 weeks to recover. And then we also know that potentially 10, 15% of those people take more than 3 months. Now, the problem is usually at the time of within the first week of the injury, we don't have a great idea who's going to be 3 weeks, 1 month, or it's going to be 3 months. We have a general idea, but we really do not have a solid crystal ball. So that's some of the fundamentals of what we're dealing with. Now, in terms of what are, generally accepted principles, like what happens, what should someone do if I've, potentially fallen, hit my head skating, and I want to get back to whatever my activity is? Well, what we say is that acute in the first 24, 48 hours, rest is important and education is important. Those are the two 100% the most important principles associated with managing concussion. In addition, even going after the fact that you've already ruled out more serious issues, rest and education are the fundamental pillars acutely. Now, the problem is that rest has a bit of a bad name in the concussion space. So I need to break this down a bit more. What is rest and what is education? Rest is not jail. And what we say by this, jail is obviously isolated, confined, not allowed to do anything. And historically, that's what people interpret rest mean. Okay, you've had this brain injury, you potentially have, neurometabolic issues and blood flow issues. So don't do anything because you're going to damage your brain. And this translated into people literally not doing anything. That is where this term jail kind of came from. We don't advise that, and I'll get to what's important a little bit later, but rest is not jail. And rest is also not cocooning. So not getting your bed sheets, put them over their shoulders, turning off the TV, closing the blinds, and no communication. That is not rest as well. And I think that's really important to define what rest is not. Now, the third point is clearly saying what rest is. And rest is relative. And this depends it depends on the individual on how unwell they feel initially and what their main complaints are. So for example, if my symptoms were predominantly headache, then what is stopping me from using my cell phone? Or what is stopping me from potentially watching 20 minutes of TV, whatever it may be? I think it's important to keep in mind that rest should be relative based on how unwell someone feels. If they don't have light sensitivity, if they don't have any issues watching TV, then I don't think we should consider not shutting those away from our life, because it's relative to how they're doing. And I think that's a real important piece for health practitioners to get that information across to their patients and for people to understand that it is relative to how they feel at that time. So it's also important to acknowledge what is education. And that sometimes is missed during a clinical appointment, because you got to get on to the next person. You give them a diagnosis. They now know they have a concussion. And sometimes clinicians see so many concussions that there's just an expectation that, well, they probably understand what I'm saying. And the reality is they don't. And education is a really important facet to acute management. The patient should know what their expectations are about how they're going to feel. Like, if they are sad, if they are, anxious, if they have emotional outbursts, is that normal? And the answer is yes. And, will they have sleep difficulties? Yes, sleep difficulties may be a symptom. Some people sleep tons and some people can't sleep at all, but both are symptoms of concussion. And so it's really important that people have an expectation. You normalize what could happen during that process. And education is also helping the individual understand what a concussion is, going through the process of just giving them the basics, because they've just been told, someone has just been told they have a brain injury. And often when that happens, a lot of people kind of, forget about 90% of all the other communication, because they sit there ruminating, like, I've been just told I have a brain injury. I have a brain injury. What am I going to do? Can I go to school? So it's really important for practitioners and even patients to understand what a concussion is. And so those are important facets acutely. Okay, motoring through here. Now, concussion is what I often refer to. This is not my wording, but people do accept this, that concussion is the injury of individual differences. And I think this really goes into why we see divergent or varied recovery pathways. Because I can give you an example, number one. Someone has a concussion, person one has a concussion, and really they're tired, and they just have, that's really predominantly their symptom. They have no comorbid issues, so they have no neck issues, and premorbid, well, they have one prior concussion, so that is their premorbid. That's what they bring into the event, and they don't have any comorbid, and they have one symptom complaint. On the flip side, example number two, well, this person may have, fatigue difficulty. They may have balance troubles. They may have extreme headache. So now they have a different symptom cluster, and also they have neck pain. They have potential range of motion issues. They have discomfort around those. So now their second ring, their comorbid ring, is much different than example number two. And then they also have 3 prior concussions. And in addition to that, they also have a history of anxiety. And so, oops, if I can just go back there, visually, these things are 2 different kind of concentric circles. Now, the question is, you can ask yourself, based on these 2 visualizations, should this person be treated the same way? They're given the same diagnosis. They both have a concussion. And so should they be managed and should they be educated? Should they have follow-up in exactly the same way? And if we just measure the 2 circles in itself, the answer is probably no. And so I think that's why we often say that concussion is the injury of individual differences, because you just can't put a blanket across every single case being the same. What is unique about athletes and return to athletics? And most often athletes or athletics in general, we're always told that they're special, they're unique and all those things. And don't get me wrong, I come from the sport concussion realm, so I can say that. And every population has really unique attributes. And I think it's just important to at least acknowledge what's unique about the athletic population. First and foremost, when an athlete is told that they have a concussion and that they're not allowed to do things, you have to keep in mind that their identity is often tied to sport. So you've taken away from that. Their main thing that they attribute, they define themselves out, they're not allowed to do. And so, each athlete has their own different level of athletic identity, and there's a spectrum on that. But athletic identity is an important piece in how we need to consider how someone's managed and considerations in their recovery process. Point number 2, for athletes, they love to move. For the most part, 90% of all athletes love to move, need to move, sleep better when they move, always are participating, always practicing, constantly being active. Have a concussion, can't do anything. You gotta hold on, gotta wait for at least 48 hours, and then we're going to kind of reevaluate and kind of progress things along. So there's another thing that's important. You can think of deconditioning. You can think of just that cathartic kind of energy that they have is potentially going to build up. That's unique to athletes. And the third one here is their community, their social network, how they define themselves is also part of the culture of sport. And now we tell them that they can't go to practice. They can't go to, they can't participate. You got to watch out for busy environments, all these things. These all together, can be one or many things that impact a person's recovery process in terms of deconditioning, their athletic identity, their confidence, self-esteem, and just their social isolation or their network has been altered. So I think it's really important when people are managed or considerations for returning to athletics and dealing with athletes, that we need to be aware that they have some very unique characteristics associated with sport participation and the recovery process, particularly how it relates to concussion. So the next thing here is, okay, so you're allowed to, we're going to call it relative rest for 24 to 48 hours. And then we're going to be sure to provide them some education. And then the hard part starts, reintegration. And this is really where we need to get people, on the road to recovery, feeling better, back into athletics, and obviously doing what they love to do, involved with their team, and then eventually, hopefully, playing full sport again. So that's the meat here. Now, when we think of a professional team, and well, who's going to help with reintegration? Well, here's the list, and I have no bias here of the list, but that's what I Googled today as a team picture. You can see all the players here. Yes, these are the guys all wearing the jerseys, but then there's a whole bunch of other people around in these jackets that don't have jerseys on. And this would be the support staff. This would be the trainers, the assistant trainer, the sports psychologist, the sports scientist. They are well kind of done by having tons of support to helping individuals or helping players get back into the athletics. Now, as you move down in the sport model, usually less and less individuals are involved. So someone has to be responsible for reintegration. And most often in community sport, it's potentially a trainer, it's sometimes the family physician, it's sometimes the team therapist. Nonetheless, this is what they're trying to get across when you reintegrate someone back to sport. And this is what's referred to as the consensus statement of concussion in sport. This is what the agreed upon by all the experts of what the stages should be going through returning to sport. So in the best case scenario, if someone has an athlete has suffered a concussion, they feel better in maybe 2 days. Well, you can see here, there are 6 stages to this process. And really, athletes are only allowed to pass through 1 stage per day. So if you've had 2 days of symptoms in some perfect scenario here, then they're going to be out at least a week or 8 days, because they can only move through different stages each time, from stage 1 to 2 to 3 to 4, 1 day at a time. You can't just run through all of them in 1 day. Now, if we look at these principles, it talks about, doing some daily activities, gradual reintroduction, and it says light aerobic exercise. Okay, that's informative. I can do light aerobic exercise. I can walk. I can go on a stationary bike at a medium pace, no resistance. And so you can read some of these. Stage 3, sport-specific exercise, running, skating. You may feel like you're getting somewhere here. Unfortunately, my belief here, if I'm critical of these stages, these stages and these guidelines are written for practitioners and experts that know how to kind of read this information and translate that into practical terms. But the reality is, it's 80% of people that deal with this, these guidelines don't provide practical recommendations or knowledge translation. For example, light aerobic activity, stationary bike. That makes sense. Medium pace. Okay. If I'm critical on this, how long? How long should I do this? 20 minutes? 10 minutes? 30 minutes? Can I do it back-to-back days? And what's the resistance on this bike? Can I go for a run? Why do I have to do a stationary bike? And so we can look and accept these stages as potentially useful, but the reality is they lack knowledge translation. They lack practicality. If I'm a person that's just hit my head and I want to potentially go through this process, what am I going to do tomorrow? What if I'm going to start with sports-specific exercise, for how long? What type of drills am I doing? And so I've been quite critical on some of these things, that we need better practice guidelines and solutions for people going through that process. Now, I will try to simplify this, because we, at U of T, and I'll give credit to probably my mentor, Dr. Doug Richards, who's really we kind of work together and trying to help formulate this, but I give him a lot of credit on these things. And if we try to simplify this, really in a return to activity or return to athletics framework, we're looking at 3 key things that we need to keep in mind on for progressing someone: physical elements, cognitive elements, and sensory elements. So if this is one thing that you can remember here this evening, is these 3 things. If I'm going to return to sport, athletics, I got to think of 3 key pillars: physical, cognitive, and sensory. And so what I mean by that is, physical means like cardiovascular issues, or raising your heart rate, or moving in space, physical. Cognitive means thinking. How complex is this task going to be? What's required of me? Do I have to think? That's going to be cognitive issues. Sensory is going to be how bright lights are and how noisy it is. Very straightforward. So we have 3 real components. So if we have at least the exception or expectation that, yes, we'll start with aerobic activity, well, what is that going to look like? Well, really what we're doing in this initial stage, is just a physical element. We're just trying to increase that cardiovascular element to see if we stress the physical system, will someone feel unwell? And we do that, we suggest a stationary bike, because if I say go run outside and you feel unwell, then me trying to advise on sport or return to activity, I don't know if it was because you were running and it's your kind of perception, you're monitoring, obviously it's quite a cognitively complex things with crossing the road, cars, bright lights. I don't know if it's one of those things or if it's the cardiovascular issue. So if we just try to say, let's start looking at the physical symptoms, get on a bike and stress the physical symptom. Then when we move to stage 3, we're going to add an element of physical movement. So physical being moving in space. but we're going to keep the cognitive element and the sensory elements low. And what I mean by that is we're not going to make it hard for them. It's not going to be cognitively complex, and we're not going to have bright lights or loud sounds. But as we move through the progression, we're going to layer on cognitive and sensory elements. So when we get to stage 4, to progression of complex drills, this is where we see the cognitive element, because we're going to say, okay, we're going to have teammates involved, make a pass, make a choice on this. And so you're going to, again, add an element to the physical component. And then here, as we get to the element of sensory, or stage 5, where we're under the bright lights of a basketball or court, we have other players around. We're essentially simulating that environment, but now we have all components of physical, cognitive, and sensory all under a controlled environment to restore confidence and those fundamental skills. So that's really the essence of a return to play or return to activity strategy, is the 3 pillars of physical, cognitive, and sensory. Now, I am mindful of time. I've got about 4 more minutes. So the question is, who to see return to athletics? And it depends on the stage. I think in the acute stage here, so we have acute, so that's when the first 5 minutes to the first 24, 48 hours, the first time you see a medical professional. This should be a physician. Or in Canada, we accept also a nurse practitioner. But the idea here is this is a medical issue that they need to rule out potentially more severe or other health issues. And really here, this is just informing them, ruling out more serious injuries, providing them education, providing them what a concussion is, and just telling them what the next steps are. Now, as you kind of move through this process, subacute, often in sport, return to athletics and reintegration, this often involves usually a team trainer, a physical therapist, a kinesiologist to help with those aspects of return to sport. Then, as we get into, I'll call persistent symptoms, and this is when people aren't getting better after maybe 3-4 weeks, and they're not getting better. Well, who do they see? And this really depends on the type of symptoms they have and the severity for which they have. So if they have potentially major headaches, migraine issues, maybe they need to see a neurologist. Maybe they need to see a specialist that deals with headaches. And maybe if it's visual or ocular issues, there's a consideration, maybe, getting a consult with an optometry. And so really the persistent symptoms issues really depends on, what type of symptoms they're complaining of. And that usually directs the care at that point. But really, we often, from starting at day 1, it should be it is a medical condition that needs to be overseen by that individual. And they're usually like the quarterback in that process. And if they need that relevant expertise based on how their symptoms are going, then they will reach out to those respective individuals. Last couple of slides here, and I got 2 minutes. So return to activity concussion, I want to say some pain points in the system. And so I've kind of walked through this kind of perfect system that they just get better and that's all fine and dandy, you just reintegrate them. But the reality is that recovery may involve 1 or more health care professionals. As I said, it depends on the issue, on when their symptoms are still potentially persisting. At the same time, even in a very acute setting, if they are not familiar with the return to the play process and they need that additional kind of guidance, again, physiotherapy for helping with exercise progression, kinesiology is obviously a discipline that is gaining some more traction in that space, as well as it could be a situation where they may have a team trainer that can provide that. The second point is that as much as we believe that recovery occurs through this nice smooth line, it's not often the case. Humans are, again, an aggregation of multiple things, and everyone has some levels of ups and downs. And so it's sometimes there are setbacks and it's not as straightforward as we hope. The one thing is that in the concussion space right now, particularly in Canada for the most part, and pretty much everywhere where we're under time constraints, it's very time consuming for clinicians because often concussion management is about understanding how they've done since the last time they've seen you, what has given them issues, what type of exercises are they doing. So it's a lot of information gathering, figuring out what's best moving forward, and that takes time. in addition to any potential physical assessment they would do. The fourth piece here, again, I've only spent 25 minutes on just some of these principles, and I'm sure you'll probably have questions yourself, but knowledge translation, what are the frequency for which you can do things? What's the intensity? What's the type? What's the duration? These are all principles that we are still need articulation and issues with adherence. If you send someone away and come back in 1 week, they go do something a couple of days later and they feel unwell. Well, how do they communicate that back? Often patients just wait, and that's not the greatest thing for them. So the idea of making sure for adherence, confidence, how do you support someone in between these time points? Because really, it is this kind of ebb and flow often with concussion recovery. And there is a gap in this continuity of care. And I believe this is one of the kind of the pitfalls of concussion management. Is you see someone one day, you may not see that practitioner again for 7-10 days, even a couple of weeks later. And that seems to be a pain point within people's recovery because they may not know what to do at day 4 or 5. They may have questions that they can't get answered. And, concussion is just one issue that I think technology offers, some support. And we're seeing some promising in many health conditions for that. And this is one of the key things that I believe will be important moving forward, is that I think down the road, we will see technology helping with this knowledge translation aspect and getting that information, the right information of what exercises people should be doing, how long they should be doing, and if it's not going well, supporting them through that process before they get back to see their health professional again. I am 2 minutes over, so I'm not going to take much more time, but this is one that I acknowledged at the beginning of the presentation, that one of those exciting opportunities being in a clinical research environment at the University of Toronto. Our research team, clinical team, has developed a digital platform that we believe will help support people as a complementary care process in between clinical appointments. And this really, we believe, for returning people back to activity, is that supportive environment to help provide them guidance, help with that knowledge translation, pivot if they have symptoms, and provide more efficient kind of clinical care with those in-person individuals. Again, this is never going to take away from a clinician's time or health care professionals, but I believe, and we are seeing some very promising information, that this digital solution offers a very complementary platform to enhancing care. So time here, I think I'm 3 minutes over. But this was the agenda that I was hopefully going to be able to address, and I think I did as best I could, the time constraints, but we still have 25 minutes or so to hopefully clarify any of the gaps that I missed, and hopefully Dr. Wenberg can take over as well. So thank you, and I'll stop at this point.
Great, thank you so much. That was a really great, very clear presentation with some great information. So just to remind everyone, please, this is your opportunity to get your questions answered. So put those into the Q&A. And I'm really pleased to introduce Dr. Wenberg, who's going to be joining for the Q&A section. I'm just going to quickly introduce Dr. Wenberg. He's a professor of medicine, neurology at the University of Toronto and director of the Clinical Neurophysiology Laboratory and Mitchell Goldhar Magnetoencephalography unit, the Krembil Brain Institute at Toronto Western Hospital. And he is involved in sports concussion research and clinical care, and a member of the NHL and NHLPA second medical opinion list. So he's going to join Michael in answering questions this evening. So I'm just going to pull those up. So Waman asks, I don't have issues with aerobic exercise, for example, the stationary bike. At what point could I potentially return to the gym, lifting weights, etc.? Also, is it wiser to avoid lifting weights altogether, given the additional biomechanics involved?
Yes, that's a great question. I wish I could have probably dived into the sequence of the different stages a little bit more, and if the transition that we would make in this situation from if you're okay with aerobic activity, there is this intermediate stage. What we often do is we do intervals, and so this interval situation would take your heart rate up, bring it back down, take it up, bring it back down, just to ensure, again, a little more of a physical stress. But after that, assuming success, that what you're suggesting in this situation, we would then move to body weight exercises. And so going into the gym, doing your body weight squats, kettlebell squats, lunges, push-ups, all those things, assuming that goes well, your next progression would be resistance weights as well. Now, you want to kind of be careful not to go right into Valsalva maneuver, kind of lifting or deadlifting as much weight as you want. You want to start off on high reps in a high rep situation and not high resistance. And then as you successfully feel okay during that, your final stage of going through the gym would be a situation of high resistance weights.
Great, thank you. Leslie asks, your timeline for symptom onset is very specific, up to 24 hours. Can you explain the findings behind this narrow time frame? I experienced delayed onset beyond this as a persistent concussion sufferer.
Yeah, so the delayed onset one is, I would say it's a young area of research. There are about 3, I think maybe 4 peer publications out there, and most of them have kind of suggested what I've articulated here. So if we just start off, let me back up a bit. If we just start off at the consensus statement, there is an acknowledgement that symptoms can come up as far as 24, and I'll stretch it out to 48 hours after the injury, after the event. When we look at issues, when people doing studies, when they try to classify how what time is delayed onset, what is the percentages of it, the ones that I've articulated is that most people, 50%, have symptoms around an hour, and then again 75% within 3 hours. But don't get me wrong, that means there's still 1 in 4 people are beyond 3 hours. My point there, I think my main point is, sometimes what we see is people come in a week, 10 days after this concussion, and they say, I just, I have symptoms now, and my headache's killing me, and it's from the concussion that happened 10 days ago. My point here is very atypical. Not saying impossible, very atypical clinical presentation. But I'll let maybe Dr. Wenberg also maybe chime in on that one as well.
Well, I don't know that I have a definitive answer, or even if the question refers to perhaps having delayed onset after a second or a third, or it looks like you've mentioned there a persistent concussion sufferer. So maybe that might be a more typical thing after a concussion, number 4 or number 5. I think Dr. Hutchison's comment is a good rule of thumb, because many of the symptoms of concussion aren't specific to concussion. So if it's not really closely related in time, a confusing issue becomes even more confusing. So I think it is a good rule of thumb, but I think most clinicians are open to outliers as well, and would take it seriously.
Yeah,
I don't know if that's a helpful answer or not.
Well, I think it's a good point. And the one thing that we often say is that we're not dismissing that someone has symptoms. So we're not suggesting, there's going to be no suggestion. A clinician is not going to suggest that you're potentially lying in this situation. You don't have these issues. I think what's important is that if the time window gets further and further and further away, it's the duty of the healthcare to potentially think of other reasons that could be the source of your symptoms. That's what I would add to that.
Okay, thank you. Hema asks, can you comment on non-sport induced concussions secondary to falls? Can it be as symptomatic and severe?
Yes, in a word.
Exactly. I think it's a pretty, yeah, I don't know if we can elaborate too much on this, but you think of the mechanism itself. A fall biomechanically is very similar if you fall and hit your head on a cork, right? Like those things are very similar biomechanically. And more often you see maybe a shoulder to, a head in sport, but there are analogous biomechanics in sport that are no different than non-sport.
Great, thank you. Athletes who have had many concussions over a career, such as Eric Lindros, versus one major concussion, who has the worst prognosis and what are the long-term impacts to the brain?
I will blatantly start off with, I have no idea in terms of any one individual who's going to be worse off. I will kind of tease out one point here about multiple concussions for a single concussion, who's going to be worse off. I don't think anyone can give anyone a definitive answer, but what I can, make a suggestion on is who's more likely, who should maybe not continue with sport participation is something that I could probably better answer. And what we mean by that is some people come in and say, this is my 5th concussion, how am I going to be 20 years from now? I don't know who can tell you how you're going to be in 20 years, but probably not with good certainty. But what I can tell you, if you've been in and you've had 5 concussions, and we can start to see a pattern that the mechanism seems to be less of a mechanism, and that your symptoms are worse each time, and that the proximity, the time duration between each event is shorter, then this is when we start to have a conversation saying, maybe sport is not the best thing for you, because there are a few kind of potential flags, we call flags, short duration between injuries, increased symptoms for each injury, and potentially less force. But to say that there's a number that makes someone worse than the other, I think you'll be hard pressed to get a very confident answer from someone.
I would agree. We just don't know. It's an area of active interest in everyone who researches concussions, and it seems to be that either of those scenarios can lead to no long-lasting effects or to terrible effects. And I personally think a lot rests in what Dr. Hutchison said was the premorbid state, that some individuals are just more susceptible to be long-term sufferers from concussion, and that a number of smaller concussions could equal one larger one, or one large one could be enough. It's an area that unfortunately we have no tests to sort out, no way to prognose with accuracy. So we can't answer your question with any certainty, alas.
Great. Okay, thank you. We have a question from Barbara, and Barbara indicates she's a 67-year-old female with migraines that stopped 30 years ago and well-controlled SLE, so I'm assuming lupus. She said her second concussion was 3 years ago, and I continue to have issues with any bike, 5 minutes road bike too much, or attempt to run 10 steps. Visual issues from the computer too. I've tried Topamax, vision therapy, physical therapy, etc. I would love to be able to do the bike or elliptical, which I could after the first concussion. Is there any hope to get back to it?
I think I'll let Dr. Weinberg start here.
Well, I wouldn't say there's no hope. Let's start with on the optimistic side, but I certainly acknowledge the problems you're having, and I think it would be a lie to say that we wouldn't want to think you're in a worse situation than others because of the lupus and because of a very strange and still poorly misunderstood connection between migraine type headaches and lupus as an entity. And the inflammation of lupus combined with the unknown sorts of inflammation that go along with concussion and post-concussion, we can only guess make things a more complex matter. And, it's great that you got over the first one perfectly well. It is a little bit, it's a sort of story we hear and we think, well, this isn't as good a sign that it's not getting better. We would think that, yes, your lupus and the migraines and the link between those two are making it more difficult. but I certainly wouldn't rule out an eventual recovery. And I think, you have reason to cross your fingers and hope and just try to keep doing what you can. And I don't have, Dr. Hutchison may have more specific examples or advice as to what to do physically than I would, but I would at least say there's some hope. Yes.
Yeah, I'll be honest. I don't have too much more to offer besides the fact that sometimes with exercise intolerance, we kind of even scale back from a stationary bike to walking, and then walking outside, and sometimes even more controlled if it's walking in confined like underground system to get some mobility issues and at least confidence at some level, because there's not too many, to my knowledge, medical conditions that don't benefit from activity, physical activity. So it's just trying to find the right kind of context sometimes for the activity. And so if aerobic activity on a stationary bike doesn't go well, sometimes we may change the context of the activity to see if there's a better response. But I would say, similar to Dr. Wimper, that it still remain hopeful, and because I think that there are opportunities if with rehab to improve at least your tolerance with exercise.
Great, thank you. I'm a persistent concussion sufferer 1 year and 4 months after a motor vehicle accident with complex cognitive symptoms and multiple concussions over the course of her life. At age 66, I would like to get back to my hobby of horseback riding. Please comment.
Horseback riding. That one's a bit of a under the radar in terms of high risk, to be quite honest. And there are a few sports that that I would personally avoid, and you got to look at your risk. I think there's risk of concussion, but then there's risk of injury. And as much as you may be passionate about horseback riding, and that is a high risk injury for sports. So, I often try to keep things manageable with people. I often deal with athletes that want to get back to a particular sport, that are really eager to get back, and they're potentially quite symptomatic. And I just try to keep their goals a little more manageable and say, let's reevaluate in the future once we get past certain stages. So very similar into your situation, if you're still symptomatic and you're having issues, then I think you need to, reset your goalposts on what is acceptable for progression, and then be willing to reevaluate after each time. I rarely say it's off the books, but I think it's something that you should reevaluate at a later point in time when you're introduced with that reintegration or that potential risk. But I will admit, in the concussion space and injury space, it is an activity that I don't think gets enough recognition of that it is high risk.
Okay, thank you. And actually, just following along those lines, we have a question. Can sports be ranked in terms of incidence of concussions and degree of long-time consequences? And they've listed boxing, football, hockey, basketball, soccer, with a special focus on boxing, it sounds like they're interested in.
So, myself and Dr. Wenberg are concussion passionate people, and I'll speak personally in my case now. I am not a proponent of a sport or an activity where the intention is to induce a head injury. And so we can start off at the sports like boxing, like MMA, where the intention to provide, to actually be rewarded for the outcome of a brain injury is not something I personally support, and it is definitely a high risk environment. Now, if we start to rank them lower, I don't like to call out, besides intentional brain injury sports, I don't like to call out, is volleyball worse than rugby? Is hockey worse than rugby? And all these, it's depends on males and females and the competition. But I think if you take the general premise, if it is an intentional contact sport, that's going to be the highest risk. Rugby, ice hockey, at least in men's, football, that's going to have the high incident rates. Then you're going to have this middle ground of where there's not purposeful contact, but it's a busy environment and stuff happens. And you can put, basketball, volleyball, soccer, those sports in there. And then you can put the stuff that you may think you're safe, but not necessarily the case. And I can put swimming in there. I could put track in there. Field hockey, you can put pretty much. I say any activity has a risk of injury because it's unpredictable. And that's the bottom line. And the gradation of differences between sport, I think, are debatable. But I've had people at time, well, I don't want my son playing rugby, I want them playing basketball. You have not removed the risk of concussion in that situation. That is not inherently just way safer. And so I think it's important people recognize that anytime you move in an unpredictable way, which sport is, the risk of concussion is present.
Great, thank you. Premorbid use of alcohol or other medications or drugs, such as cannabis, what impacts do these factors play in concussion recovery, if any?
I think I'll let Dr. Wemberg answer.
I'd be lying, or anyone would be lying if they said they knew for sure. I personally have a feeling that they probably don't play a big role, or at least cannabis in the drug category. There could be other issues. I'm not, well, I should say that others don't believe that and think that maybe there is a role to play for drugs of any sort, or unhealthy living, or anabolic steroids and things, but I don't think there's proof of that. Certainly after a concussion, the effects of medications or alcohol that used to be well tolerated can be markedly impaired. So something, with the problems induced by concussion and the decreased room one has for error in your brain makes handling those medications more problematic. I'm not sure there's any evidence as to them being a premorbid factor, although it's talked about, and there's so many people who have problems with painkillers or with recreational drugs that maybe, but we don't know. Personally, I think there's a much more plausible role for premorbid factors on the genetic level. And that, like with many things in life, you come from the factory with different genetic makeups, and if you get a hit to the head, just as if you get a hit anywhere in your body, your system approaches that to try to repair it. And those are complex mechanisms that are dealt with in different fashions and work to greater or lesser extents. And I think some individuals just have genetic makeups that allow them to more quickly clear the damage caused by a concussion than others. And when that's in a better or less good situation, I think, or at least that's what I've been thinking most recently, I think that's perhaps the most important premorbid factor. And I can envision 10, 15 years from now that we will have genetic tests that could honestly be able to identify someone who is at a very, very high risk, for example, of suffering more problems if they were to take up boxing, or if they were to choose football rather than baseball. Again, there's no sport that is free of risk. There's no activity in life almost, if you get out of bed, that's free of risk, but water skiing there, but there are certainly some that are more risky. And I think we'll have genetic markers that will allow people to make well-informed decisions, or organizations may prevent people from playing for legal purposes, but that's down the road. And right now, the premorbid thing is a guess in large part. My guess is genetics, though.
Great, thank you. I'm gonna, just looking at the time, we've got a number of, if you guys are okay, we'll do a few more, just for a few more minutes. One of them was my favorite sport is water skiing. They're saying that they've actually had a lot of concussions water skiing, and they're guessing that you would suggest not returning to this sport because it's high risk, question mark. And then we had another question too, just about heading the ball in soccer, and they wanted to comment on that.
Yeah, the water skiing one is, I would answer that based on competence of the individual. I think a lot of people who are confident it's going to be lower risk. Personally, I am not going to take up water skiing at this point in my life because of my confidence doing that activity and the potential outcomes associated with that. So I think risk is obviously an individual choice, but there are many factors that go into I think that decision. One, you have to look, what is the gratification that's going to provide me? What is my premorbid issues around that? And what is your confidence to potentially mitigate those risks? So it's not as simple as like, it's high risk, don't do it. There's multiple arrows that point into that decision choice. The second part of that question, what was the second part of that question?
There was the heading the ball and just
soccer.
Yeah.
So the soccer one is interesting, and I think there's been some legislation that has, prevented people, at least younger athletes, from heading the ball, and some sports have introduced that for good reason. Again, it's the ability to withstand those biomechanical forces, and younger people don't have the musculature and the development to create and transfer and withstand those forces. And as you move further up, when you're older and you're able to make those more informed decisions, then that being the case. But again, a soccer ball kicked from a goalie that you had halfway across the field is not an inconsequential event, and some people can tolerate it very well. And I think this goes back to Dr. Wenberg's point. Some people can tolerate that very well. Other people, and you'll see kids, they avoid the situation because they know they can't actually handle it. So I think, again, it goes back into this risk factor, genetics, premorbid issues, and tolerance. I don't have, again, in the sport of soccer, a major issue with heading the ball. I've liked what they've done is that they've made it older before you start doing it in sport. The research shows maybe potentially professional soccer players that play decades of soccer, there may be some ill effects, but I think at face value, in the context of most people's lifespan, it's a risk that I would not be too concerned about.
Great, thank you. Okay, I'm going to just squeeze in a couple more. This, I think, is a good one. So this, Sandy says, over 4 years post-concussion with ongoing symptoms, and they've been told to go beyond their comfort zone with physical activities. And they're asking, what do you think about that?
I'll blatantly just say I agree. Like, I'm biased though. my whole profession is movement and activity, so I am definitely a biased response. However, I do have these conversations with people that potentially are quite symptomatic and they're having exercise intolerance. You got to kind of raise your lens a bit and say, are we willing to try to kind of like push through, build up your tolerance, and apply traditional rehab principles? Concussion principles don't align with a lot of conditions, because you feel a little bit of anything, don't do anything. That's not most medical conditions. There's, not to say no pain, no gain, but the idea is there's a tolerance to say, if you feel a little bit unwell, that's okay, because we need to build up your reserve. We need to see if we can get you over this hurdle. And again, when you look at the big picture for exercise, there are so many other benefits for your well-being and general health, irrespective of concussion, that we have to try to invest in to try to see if you can build up your tolerance because of the vast benefits of physical activity.
Great. Okay. One more question. Let's do this one from Ted. Quite a few years ago, I played football through high school, U of T, semi-pro, and pro for a period of 16 years. Through that time, I had bell ringers as well as some serious concussions. You've talked about hockey, which I feel has less chance for concussions. Because of the much shorter season, it's imperative to get back as soon as possible because of the dollars, the money involved if you don't play. Could you please comment?
I would say the difference between football and hockey are largely player position dependent. I don't think we can just simply say hockey, football, and it's going to be very much player dependent. Offensive line, defensive line versus a cornerback versus the kicker, a hard-nosed winger versus a stay-at-home defenseman. You can make all these kind of comparisons, and it's very hard to globally say one sport versus the other. Your point is well taken that football is a 8-week, or depending on what level it is, anywhere between 10 weeks and 16 weeks, and you play every week. I guess it's also a little bit of a red flag that they only play once a week for a good reason. And so I look at this in the perspective of that, our brains are not immune to overuse kind of trauma over time. The football players, hips, knees, ankles, shoulders, to say, well, don't worry about the brain. I think realistically, we have to acknowledge that any part of your body after, professional sports over a long period of time is realistically, if we're being fully transparent, is potentially at risk for potentially some changes. I don't want to say it's going to be all negative. There's just going to be changes or necessary modifications to one's lifestyle. But that's the whole body in football, to be honest.
Okay.
I tend to agree. I tend to agree with Ted that football is a little bit worse overall, and the pressures are immense. And I think at the individual level, any given concussion could be just as bad for a hockey player or a football player, and they're very different sports. But football is a very, very rough sport, and much as I love it, to watch it, I do wonder if 30 or 40 years from now, it may be one of the things we look back on and think, how did we ever think that was a good idea? And so I feel for you, and it is a very rough sport for sure.
Great. Thanks.
Hockey, I guess the difference about hockey, you can go practice after practice, game after game, no matter what sort of player you are, and not have a concussion or have your head hit. That's simply impossible if you're playing football.
Great. Thank you. Well, thank you to both of you, Dr. Wenberg and Dr. Hutchison, and apologies for going over time, and sorry to those of you whose questions we didn't get to. But thanks so much for attending. We are going to be forwarding a short survey, so if you do have a couple of minutes, we really appreciate getting your feedback and any suggestions that you might have. And just for your information, our next session will be March 15th, and we've got Dr. Nick Reed, who's going to be presenting return to school and learning and need for accommodations. Thanks very much, and have a good night.
Thank you.